Hello and good afternoon to everyone, to all you Butterfield Trail villagers. It's Dr. Larry Wright with the UAMS clinic here at Butterfield, and I'm accompanied by two of our resident physicians who have a presentation today, as we do every month. Presentation today on a very important subject I think you'll find helpful and useful. It's something everyone's heard of, but I rather imagine, if you're like most people, you have a lot of misconceptions about the term heart failure. So we're going to talk about heart failure and hopefully help everybody be a little less scared of it, a little more understanding of how it can be diagnosed and treated, and people can still have a great quality of life despite having it. But there are a lot here to go over. Again, welcome. We try to do these talks once a month. It's certainly been different during COVID, not having you in seats here and live, face-to-face, person-to-person. Really look forward to the day we get back to that. Always love the interaction of questions and comments. There is a way to give us questions about this. And if you don't already have the number, please write it down. It's actually the same number that may be useful to you if you're one of our patients, that you can call after hours or weekends if you have a medical problem, and one of our resident physicians answers and will help you. So the phone number is 479 area code 200-9259. If you have a question, if you will call that either during the talk or at the end of the talk, one of the residents will answer it and take your question, and we'll try to answer it. Well, I think one of the things I said, misconceptions about heart failure, I think one of the things is that the term alone sounds ominous, doesn't it? Heart failure. I've talked to older adults who assume if I ever get heart failure, it's failed irreparably, and it's I'm a goner. It's for that reason the term is misleading. What it really means is that the heart is failing to pump efficiently enough to keep blood pumped forward efficiently, and so fluid backs up into the lungs, backs up into the legs, maybe into the liver, and congests these organs. So sometimes you'll hear the term congestive heart failure. Anyway, we're going to unpack all this, hopefully go over it and review it, and these two doctors are well prepared to do that. Our two physician residents here this month may look like familiar faces to you. Dr. Rikhav Vasanwala. Rikhav, I'm getting that name down. I'm getting better. Rico will give part of this, and then Tony Hoyt. You grew up in Northwest Arkansas, been here forever. You're still here. They're in their second year of our 3-year residency program, and very proud of both of them, and I think you'll enjoy this presentation. Ready, guys?
Okay, again, so my name's Tony Hoyt, second-year resident. So we're going to be talking to you about heart failure. Here, there we go, that's better. We'll just take turns moving our masks, okay. So, we were under the impression that we would be able to advance these slides ourselves and stuff, so we're going to have to modify the presentation a little bit. Hopefully it doesn't get in the way. So yeah, there's the first slide, heart failure. Okay, so the first thing, if we can press next. Okay, so these are just going to be the things that we're going over. Yeah, if you just press next a couple times. There we are. That's perfect. Okay, so what we want to talk about is what it is and what it is not. Difference between systolic and diastolic heart failure. For all of you who want, more information on the topic. We're going to talk about what causes each. There's multiple ones, and treatments and lifestyle changes. Okay, so let's go to the next slide. So what we want to talk about first is what heart failure is not, okay? So the first one, cardiac arrest. Sometimes whenever people hear the word heart failure, they just think the heart has completely stopped, and that's what cardiac arrest is. That is not what it is. The next one, some people think it's just a form of a heart attack, or if you get some blockage in your heart arteries, that can cause the tissue to die. It is not that. And as you can see on the next bullet point, a heart attack or coronary artery disease in general can lead to different forms of heart failure, and we'll get to that. Okay, so next slide. So what it is, think about it. Give me 1 second. Oh, there we go. Rather than thinking of the phrase heart failure, I want you to think of heart struggle, or a noticeable heart struggle, okay? So the definition, and kind of in layman's terms, it's your heart's failing to adequately send enough blood, and whenever I say blood, think of oxygen and all the nutrients that it carries, to the rest of the body, okay? And your body will start noticing that eventually. On top of that, the lack of forward blood flow, there's also kind of a backup of blood. If your heart's not getting blood out fast enough, it's all still coming in at the same rate, so it starts to cause this backup, and so think of it like a toilet starting to flood. And next thing is heart failure. It's a progressive disease. It's not something that can be cured. The whole idea is to slow it down as much as we can and decrease the symptoms as much as we can. We want to be able to prolong life for as long as we can, as well as give you the best quality of life possible in doing so. Okay, so next slide. So like I said earlier, this is the kind of the heart failure plumbing explained in a quick equation. You've got enough blood reaching the heart. It's all coming to the heart at the same rate. But you have an insufficient amount of volume leaving the heart. So more is coming into the heart than is leaving, thus congestion. The blood starts backing up, like I was saying earlier. And it starts to cause these flooding symptoms that can be flooding in the lungs a little bit. It can be flooding down to your legs, causing swelling in both of your legs. Okay, so this next slide, this is one where I was really hoping to be able to have my mouse to show you the pathway. But you see on the left side of this screen, there's the blue blood. This is blood that has no oxygen in it, okay? So it goes up into the, whenever I say right side of the heart, it's gonna be the left side of the screen. Imagine you're facing someone, so it's their right. So it comes up into the right side of the heart and down to the bottom right side of the heart, okay? And that pumps the blood up this left blue pathway into the lungs that we have up top. The blood gets oxygenated, and then it leaves the lungs, just like the graph shows, and it goes into what we call the left side of the heart, but it's the right side of the screen. This is the stronger side of the heart. It's got to push really hard to get the blood out to the rest of the body. So it's a lot stronger than the right side of the heart. So it goes down, it goes out of this left ventricle, and then it goes to the rest of the body that you see at the bottom of the screen. This web of material, those are called capillaries. That's where blood and nutrients can kind of leave the vasculature and then feed all the tissues. Okay, so in let's imagine a normal healthy person who's deciding to exercise. Whenever you exercise, your tissues need more energy, more nutrients, oxygen, etc. Whenever this happens, it sends signals to both your heart and to your lungs. It says, oh, hey, we're needing more oxygen. Let's breathe a little bit faster so we can get more oxygen to the blood that is now moving faster. And the other part is the heart starts to pump faster because, once again, the rest of the body needs more oxygen to feed the tissues. So the heart rate will increase and the breathing rate will increase to help supply that. Now I want you to imagine someone in heart failure, okay? As heart failure progresses, it's almost like your body thinks that you are exercising much more than you might actually be. So you might start feeling symptoms of shortness of breath, just, maybe with minimal movement or minimal walking. And once it progresses far enough, you might feel shortness of breath at rest. And once again, because not enough blood is being able to leave the heart, which kind of overall defines heart failure, you're not getting enough forward blood flow to the tissues, so the tissues feel deprived of oxygen, which thus tells your heart to speed up to try to compensate, and it tells your lungs to try to speed up. So that's all due to lack of forward flow and oxygen moving to the tissues, right? But once again, like I was saying earlier, backup of blood, okay? Like I said, a lot of blood is coming into the heart at the same rate, not enough leaving, okay? So I don't have my mouse here, but you can imagine this top right, this artery that's going up to the lungs. Imagine it's going retrograde flow, kind of backwards. It's getting engorged. It starts to go towards the lungs. And in the capillary system in your lungs, because of all this backup blood flow, it starts to squeeze out of those capillaries up there. It can be, it's blood mixed with all the fluids that are in blood, okay? And so this is what we call kind of water on the lungs. That in and of itself can make the shortness of breath that you have much worse. And now imagine it keeps backing up. So let's move to the left of the lungs. Now we're in the blue. Sort of vein there, okay? And it backs up into this blue side of the heart, okay? And so now all of a sudden we're getting right-sided heart failure symptoms. It keeps backing up, back down to the body, moving down the blue side on the right-hand side of the screen, left-hand side of the screen. And that's when you start to notice things like, oh my gosh, my legs are getting really, really swollen. And the longer I stand up, the worse they get. Now, other diseases can cause that, like chronic venous insufficiency. That's just where the veins in your legs are not really pushing blood up to the heart as good as they can. But heart failure can cause this as well. And it can cause fluid to back up into other organs, such as your kidneys, liver, etc. And it can cause damage to those as well. So in a nutshell, that was a lot, but there's kind of injury to the tissues in your body due to lack of forward oxygen flow, but also damage to those areas because of backflow, and all that swelling and all the different organs can occur, and it causes compression on them and causes injury that way. So let's move on. Okay, so let's just talk about a few terms before we move forward, okay? This is during the pump action of the heart, okay? There's really two main stages, all right? The first one is diastole. Diastole is when the heart relaxes. During this time, blood is moving into the to the lower ventricles of your heart, okay? Let me see here. What was I saying? Diastolic heart failure. Okay. So, and people with diastolic heart failure, they're having trouble filling these ventricles, but they are moving blood out of the ventricles just fine, just not enough is getting in, okay? So then the next one is systole. Systole, this is my little mnemonic for it, but I've underlined the S in systole and the S of squeezes. During systole, the heart is contracting, and it's pushing blood out of the heart and into the rest of the body. So whenever there's systolic heart failure, think of it more like there's a muscular weakness, and it's not squeezing properly to get the blood out of the heart. So again, diastolic heart failure, blood's not moving into the heart very well. Systolic heart failure, blood's not moving out of the heart very well. Both of those, if you think about them, it ultimately means less blood moving out of the heart. Oh, and this is just kind of what I was explaining earlier. Most of the time when we talk about like heart function, we're typically talking about the function of the left ventricle. And so if you're looking at the screen, imagine you're facing a person and you're facing the front of their heart. It's the right side of the screen is the person's left. And so that arrow that I've got pointing at the left ventricle, a lot of times this is the area that we're talking about when we're measuring the functionality of your heart. Okay, so diastolic heart failure, decreased filling. So heart squeezing just fine, just not enough blood to squeeze out. Okay, so let's talk about the first one that I want to mention. Okay, so think about a thick heart muscle. You see the heart on the left here, consider that a normal heart. You see the heart on the right. Well, if you can imagine, any blood that gets down in there, that heart is so strong, it's going to get all of that blood out, okay? But because that heart muscle is so thickened, there's not a lot of space for blood to come in. So there's a smaller filling space. And you can imagine, since the heart is thicker, it's not going to stretch as well either. Now, a way a good heart should work, it should fill properly, but it's slightly elastic, okay? And so when blood's coming in, it stretches out the muscle just enough that it can feel more than if it were to not stretch out at all. So thick heart muscle, that's one of the causes of diastolic heart failure. But now, what causes thick heart muscle? I just got a few examples here. So our culprits down at the bottom left. So high blood pressure, okay? I want you to think about whenever the heart has to push blood out, imagine there's so much pressure in your vasculature on the outside of your heart. Your heart is having to push against that high pressure. Therefore, it's having to push harder. So just think of it like the Arnold Schwarzenegger of hearts. The more it has to push against this really high blood pressure, it's working harder, the heart is going to grow. And that can cause, like I said, this thick heart muscle. Another example is aortic stenosis. If you look at either of these hearts, if you kind of look at the right side of the heart, there's this tube that goes down into it. Well, that's where blood leaves, and there's a valve right in that spot. Sometimes that valve can get really hard. It's not exactly high blood pressure that's causing the thickness of the heart, but the heart is having to work much harder to push blood past this really hardened valve. It's not opening very well. So once again, the heart is just getting a good workout, and it gets thick and strong due to that very reason. So once again, this is an example of diastolic heart failure. Now here's another one. It's less easily explained, but it's kind of more common, especially with aging and especially with chronic diseases. Okay, so infiltration of particles, that's what I'm calling it. Imagine stuff or junk kind of over time gets deposited into the heart muscle. This is not necessarily making the heart muscle thicker because it's growing stronger, it just makes it much less elastic. And because it's much less elastic, it doesn't have that extra stretch as blood's coming in to allow more blood to come in, okay? And so this heart on the left, I want you to imagine that is a healthy heart. Yeah, that's a horrible picture, I'm sorry about that, guys. But so the one on the right, all these arrows are kind of pointing outward. Just you can imagine there's less arrows pointing outward, so it's not able to get good enough stretch. So what are some culprits of that? So now the bottom right-hand side, there's something called amyloidosis. A lot of different things can cause that. I'll just kind of mention a few. With increased age, some people are more prone just by their genetics. There's, I'll call them wasted, misfolded little proteins that over time get deposited into the heart, and that can cause that heart muscle to become less restrictive. But it has the same ventricle size, it just can't stretch very well. Now, chronic disease in and of itself can cause amyloidosis. Anything that's inflammatory for a long time in your body increase the amount of this said protein that I was talking about, these wasteful proteins that get deposited into the heart, making it not stretch very well. Now, there's a bunch of others that are, a little bit more, I call them zebras. You don't see them as often, but there are conditions that some people can develop, like autoimmune conditions where non-protein-like material, other things get deposited into the heart, making it not stretch very well. So I would say in a population of people 65 and above, the most common form of heart failure that you'll see is this diastolic heart failure in the bottom right-hand screen, more of this restrictive sort of feeling. Okay, so let's move on. Now let's go to systolic heart failure. So poor squeezing ability. So plenty of blood gets in, not enough gets out. So at this point, the heart's like, hey, slow down, blood. I can't get it out fast enough, okay? So think weak or damaged muscle. All right, so this picture at the bottom left-hand side, it's kind of, imagine I cropped out a piece of the heart, and this is a ventricle. It's upside down. Don't worry about exactly what it looks like, okay? But if you notice, these all represent what I call dyskinesis. That means kinesia means like movement, and it's not moving properly. So you look at these different pictures. The one at the very left, whenever a heart contracts, the muscle thickens, and it makes the ventricle size smaller, thus pushing the blood out. Now look at the second picture. There's a little piece of the heart that's not thickening. Or it's barely thickening. Then further over, there's a piece of the heart that's not thickening at all. And then all the way over here at the right, it's just a very abnormal movement. So the number one culprit of what causes this dyskinesia is when someone has a heart attack or ongoing coronary artery disease. So what I mean by that is if you don't have enough blood flow to feed the heart itself, there can be areas in the muscle that die. Therefore, they are not going to be flexing very properly. And so those will cause weak spots in the heart that decrease the total amount of blood that it can push out, okay? So let's move on. There's a lot of things that can cause this dilated looking heart. Okay, so you notice the top right, that's the normal one, but then this one in the middle, imagine it's bigger and the muscle is much thinner. A lot of things can cause this, even viral things could cause it, but one thing I want to point out is, kind of like these pictures over here on the left that I said, like coronary artery disease and heart attack, the long-time sequela or ongoing changes can eventually lead to this dilated what we call dilated cardiomyopathy. Even pictures from the previous slide where with the diastolic heart failure, over time, even though that muscle was thick, well, it can start to grow in a more length of a direction and become more of a dilated heart. And so you can imagine these are just really cruddy muscles and it's not pushing the blood out very well. So a lot of physiology. I promise he will get, Dr. Vasanwala, he will get kind of more to the nitty gritty of, okay, what does this mean to me? But now we kind of have a better understanding of what heart failure is. And we'll have time for questions at the end if you guys have any questions about what heart failure is. So we can do the next slide. Okay, heart failure in older adults is often multifactorial in origin. Oh yeah, one thing I didn't point out earlier is there's systolic heart failure and there's diastolic heart failure. A lot of people can have both. Just keep that in mind. So heart failure in older adults is often multifactorial. The next part, so hypertension. So this is the most common, antecedent, that's not a word I often use, cardiovascular condition in both men and women. So like I said in that first slide, hypertension over time, that causes that muscle to get thick, like I was saying, and it doesn't allow much blood to get in. So that's the most common kind of condition that can lead to heart failure as you get older. Okay, so the next most common is coronary artery disease. So this one's more likely to cause the systolic heart failure where you can't squeeze the blood out very well because of scarred up heart tissue, basically. There are other common causes, like I was saying, valvular heart disease in general, whether those valves be too hard and the muscle has a hard time pushing it through the valves, or if the valves are too floppy and it pushes it out just fine, but it all flows back into the heart sometimes, and that can cause that dilated heart picture, causing systolic failure as well. So next slide. And this is the last slide, and then I'll let Dr. Vasanwala speak. Actually, were you planning on talking on this one?
This is 12. Yes.
Okay, so Dr. Vasanwala is going to give you guys the information that you might need on a daily basis. Here we go.
Okay. All right, thanks, Tony. Yeah, that was great. I was going to, after kind of that physiology, just get into some statistics about heart failure, then also the medicines that we use to treat it. So heart failure, like it shows on the slide there, is the leading cause of hospitalization and rehospitalizations in the United States. So just some statistics about it. It affects more than 6 million Americans. Almost 1 million new cases are diagnosed each year. There's a lot of hospital admissions with this and a lot of readmissions associated with chronic heart failure as well. So the incidence of heart failure increase as we age. And like it says there, the median age of people who are hospitalized is about 75 years.
And median is just our more favorite version of checking the average, just letting you know.
Okay, can we go to the next slide? So some of the signs and symptoms of heart failure, and this is mainly in older patients. It is important to note that some of these signs and symptoms may not be present in older patients, but most commonly you notice that shortness of breath when you're exerting yourself. Maybe you notice more shortness of breath doing regular daily activities than you used to notice. Fatigue, orthopnea, meaning an example would be that you can't lie down flat at night to fall asleep. You may need a few pillows behind you to prop you up, like sleeping on a lazy boy would be easier than lying flat on your back. In younger patients, these symptoms can be much easier to diagnose. They may have things like fast heartbeats, increased pressures in some of their veins, easier to pick up on physical exam as well. Mine died. Yeah. Okay, sorry about that. My mic died over there. So in older patients too, we can see some of these symptoms, including listening to your lungs. You may have some fluid buildup, like Dr. Hoyt was saying, some leg swelling, which we can see on physical exam as well. Most of the time, to diagnose, we can use some of these signs and symptoms, but if we go to the next slide here, the main way is an echocardiogram. So that's an ultrasound of your heart. It gives us a good idea of the how hard your heart is pumping, how well it's pumping, if there's any valvular problems, if there's any thickening of that heart muscle. Some other tools that are helpful is a chest x-ray. So a chest x-ray may show some fluid buildup back in the bottom of your lungs. It can show an enlarged heart, which can help diagnose heart failure. And then, like Dr. Hoyt was saying, a lot of different things can cause it. The most common is long-standing hypertension, so high blood pressure. Previous heart attacks can cause it. Coronary artery disease is associated with heart failure. There's also blood work that we can do. So, like I mentioned, the echocardiogram is really the best way, but a blood test known as BNP, it stands for brain natriuretic peptide. It's released, it's a kind of a misnomer, it's brain natriuretic peptide, but it's released in your body when your heart the cavity is stretched out. That's stretching due to blood backing up and not being able to be pumped out as well. It releases this this hormone, and then we can detect that. We can detect that on blood work to see if you're developing heart failure or if it's worsening. And there are different reasons. It's not just heart failure that this is elevated, so there are different reasons why this can go up. Chronic kidney disease is one of them. Age is one of them. As we get older, this level can go up as well. So it's not quite as specific. It's not a test that we can look at and say, if this is high, you have heart failure, but it's just another piece of the puzzle that we can use. All right. So just an overview of the treatment for heart failure. So there are two basic treatments that we do for heart failure, and one is related to improvement in life expectancy, an increase in mortality benefit. The other one is an increase in just your symptoms. Heart failure can cause, like we talked about, shortness of breath. It can cause leg swelling. It can cause a lot of symptoms that are uncomfortable. So there's that part of therapy to treat some of those symptoms. The other part of the therapy is to help the heart prevent it from having those changes which lead to bad outcomes. And those are the drugs that help with living longer. They help with mortality. So another important thing to know about heart failure is also some drugs that we should try to avoid, and also dietary things that we can do. So some drugs that we do want to avoid are things known as NSAIDs, medicines like ibuprofen, also known as Advil, naproxen, also known as Aleve, meloxicam, also known as Mobic. So these drugs really are okay over the short term for a few week courses, but typically in patients with heart failure, we want to avoid them for the long term, as they can make heart failure worse and even work against the medicines that we use to treat heart failure. Another important thing that we can do to help with heart failure, can you go to the next slide, please, is diet. So having a reduced sodium intake, typically usually less than 2 grams per day, if recommended by your doctor, can help prevent some of the swelling. It can prevent fluid retention, which can help in heart failure. Limiting your fluid intake may also be an option. Those are typically reserved for more severe cases of heart failure or exacerbated cases of heart failure, someone who has it and they have a worsened case of it. So it's really kind of a personal thing you develop with your doctor after seeing them for a while to have an optimized diet to help. And then also regular exercise helps as well. So things like walking, swimming, water aerobics are great on the joints. So these sorts of things will also help out with heart failure. Because it is really easy when you develop heart failure to have these symptoms and then become more sedentary. It's easy to do less exercise, sit on the recliner more, avoid the things that not only help heart failure, but also help out just our general well-being.
And just as a clarifier on that, like we said earlier, minimal exertion could make you become symptomatic. And so you're thinking, but now you're telling me to exercise. The whole idea is do enough exercise that you can tolerate and try to tolerate more and more and more to hopefully keep you healthier in the long run. And that could actually decrease the amount of strain on your heart over the long run as well. Anyway, go ahead.
Yeah. No, absolutely. That is important to note that when we say exercise, we don't mean to, run a marathon the next day. It does mean to start off very slowly, do what your body can tolerate, and build up slowly so you get that endurance to be able to exercise more and more. So, yeah. Okay, so here are some medications for what Tony was talking about, systolic heart failure. This is typically heart failure with a reduced ejection fraction. So some of these terms, okay, so systolic, like Tony was saying, was when the heart squeezes. Ejection fraction. Ejection fraction is the amount of blood in that left side of your heart that gets squeezed out by your heart's pump. Typically, 60%, about 60% is normal. Patients with systolic heart failure tend to have a reduced ejection fraction, so their ejection fraction is below that level. All the way, it can get very low. It can get even low into the teens, the 20s. So there's a wide range of reduced ejection fractions. So some of the medicines that help, they help with your life expectancy. They help you live longer. One of them is beta blockers. So beta blockers work by blocking a receptor on your heart that actually slows down the heart rate and then allows it to fill up with more blood. This allows for better pump. It prevents the heart from also remodeling. It prevents it from having those that increased musculature, that thickening of the heart that Tony was describing. Not all beta blockers are indicated for this, so just the ones that are more specific to the heart, like the ones listed there, metoprolol, succinate, carvedilol, those will help with, like it says on the slide there, ventricular heart remodeling. Another class of medications that helps with this are ACE inhibitors. So medications like lisinopril, ARBs, which are a sister drug of ACE inhibitors, also help. An example of that would be losartan. So these do the same thing, but in a different way. They block an enzyme in your body that allows for your vessels to dilate, increasing blood flow. So this allows your heart to get more oxygen and prevents it from thickening. It prevents that thickening of the heart that can happen in heart failure. Another drug here is a diuretic, spironolactone. So this is a special class of diuretic. This and another drug called eplerenone. Those are the two diuretics that are shown, the only two diuretics that are shown to help prevent or increase life expectancy, that showed a mortality benefit. So we'll talk a little bit about that a little bit later here.
And one thing I wanted to quickly interject. Earlier I was telling you our bodies have ways to compensate for lack of blood output. And it's more like, hey, this will work for the time being because we have no other choice. And so it may help you, like that your heart rate speeds up or that the muscles get a little bit stronger in the heart, but that's only for the short run. But it causes the heart failure to get worse in the long term. So a lot of these drugs kind of help prevent the remodeling inside that part of the heart to keep the heart failure from getting worse, just as an aside. Okay, go ahead.
Yep. Right, like he was saying, those are physiological responses that occur in healthy people, but then if we have this heart failure, over time that physiological response will lead to this, your heart muscle changing, which is something these drugs try to prevent. All right. So talking about ACE inhibitors here first, these were the drugs. This is an example would be lisinopril. Like it shows on the bottom half on the slide, ARBs, which are related, similar to ACE inhibitors, just work in a slightly different way. An example would be losartan. Some of the side effects of now lisinopril, ACE inhibitors, is cough. That's the most common type. Some of you probably have had this side effect with it. It occurs during long-term treatment for some patients. In this patient, if you have this side effect, you can be switched to an ARB, which doesn't have a cough as a side effect. High potassium levels is another side effect, something we need monitoring. A more serious side effect is rare, is angioedema, which is swelling of different parts of your body, which is a little bit more serious. So in general, though, these drugs are kind of the cornerstone for treatment for heart failure. These are kind of the first-line medications, along with beta blockers, that are used for mild, moderate, severe heart failure. And just a note, there are a few more newer medicines coming out that show similar efficacy to these drugs. And one of them is valsartan and sacubitril, which is a combination pill. So there are newer drugs coming out which do show similar efficacy to these drugs as well.
Yeah, a big thing about that one, it actually had very promising results in all the trials, but if you are more prone to becoming hypotensive, that is low blood pressure, these are more prone to causing that low blood pressure. So that is just something to keep in mind. Maybe you might be wondering why your doctor doesn't have you on it, and so but that is something to talk to your doctor about.
And this slide actually shows that medication here. So sacubitril, it works by increasing certain peptides, hormones in your blood. Valsartan is an ARB, like the medication we talked about. And it mentions here HFrEF is just an acronym. It just stands for that heart failure with reduced ejection fraction. It also shows the New York Heart Association class. So this is kind of the gold standard for classifying heart failure in patients. There's 4 stages. Level 1 would be that you don't have any symptoms really. Level 2 is you have mild symptoms. 3, more moderate symptoms, and 4 would be severe symptoms. And there's
like symptoms at rest. Think of it that way. Yeah.
Yeah, and not to get into all the details, but that's the general gist of it. There's things that your doctor will go through to help classify you into which class you would fall into. And depending on the class, that dictates what medicines we use to help the life expectancy of a patient who has heart failure. We talked about the beta blockers and those ACEs and ARBs. These medicines here are used to help symptoms. These medicines here won't necessarily, with the exception of one diuretic, which we'll go over after this slide, spironolactone, and in the same class of eplerenone. These ones on this slide haven't been shown to improve life expectancy, but they drastically can improve a patient's symptoms, meaning to a better quality of life. So one of the mainstays of heart failure is Lasix, or a diuretic. This helps you remove excess fluids from your body. It works on your kidneys. It can help reduce fluid in your lungs. Typically, you and your doctor compose of a regimen to take a certain amount per day. You may also take extra amounts or less amounts depending on how much weight you gain overnight. So your regimen can vary from other people depending on how severe your heart failure is. It can be used in IV as well. So if you go to the hospital with a worsening of your heart failure, they typically give it in an IV form, which is more potent to help get rid of some of your fluid. Digoxin is another medicine. This is used in more severe cases of heart failure. It works by slowing your heart rate and also increasing the pump of your heart. But like I said, not everyone with heart failure would be on either of these medicines. It depends on how your symptoms are, and for digoxin's sake, how severe your heart failure is. So, and some diuretics, Lasix is not the only diuretic, by the way. So there are other diuretics that your doctor may put you on, such as hydrochlorothiazide. Some patients don't necessarily need Lasix is a stronger diuretic. It'll make you lose more fluid. Some patients can get by with other diuretics that aren't quite as potent to help get rid of fluid. And just to backtrack just a little bit, and these medications, when you go to the hospital, we're talking mostly on an outpatient basis, but when you go to the hospital, there are different strategies that we can do to help you mainly get rid of excess fluid. That's usually when you have a worsening of the heart failure. You notice that your legs are more swollen, more fluid is backed up into your lungs, you're having more trouble breathing. There are different combinations of these diuretics that we can give to help get rid of this excess fluid. And it is important to note that we can't give these all the time because, like any medication, they have side effects. They can cause your electrolytes, certain ones, to become imbalanced. So that's something they closely can monitor at the hospital, whereas outside that's not really possible. So the treatment is really different in a hospital versus an outpatient setting. We had touched upon, this is the one diuretic that is shown to help improve life expectancy, and that's only with a class 3 or class 4. That would be more moderate to severe and severe forms of heart failure. It also shows that improves life expectancy with that and an ejection fraction less than 30. And if we remember, the normal ejection fraction is about 60 in healthy patients. So this can also be given as an adjunct to those beta blockers and ACE inhibitors and ARBs like we talked about. Some side effects with these, we do have to monitor your potassium, and pretty much with the ACEs, the Lasix, and this, it can throw off the balance of your potassium, so that's something to closely monitor with your doctor. And in terms of Lasix too, it can also throw your salt levels off too, so something to also monitor with your doctor. And all these medicines can affect the kidney. Another thing that it's important to keep regular follow-ups to monitor your kidney function as well. We just talked about systolic heart failure, or typically what's known as heart failure with a reduced ejection fraction. This slide talks a little bit about heart failure, diastolic heart failure, or diastole is when that phase of the heart when it relaxes. And typically, diastolic heart failure is associated with a normal ejection fraction. So it's what causes you to have heart failure with a normal ejection fraction. Usually, there's an abnormal pattern of your heart filling, and then elevated pressures with that abnormal filling pattern. So this is a little bit trickier to treat. There hasn't been really any clear trials that show a reduction in mortality or improved life expectancy with any of the drugs that we had previously talked about. So, you and your doctor may come up with some medicines that help with the symptoms, but there's no clear benefits, mortality benefits in any of those drugs that we discussed. It is important, though, to control the cause of some of these things. So very common condition is AFib, atrial fibrillation, an abnormal rhythm of your heart. About 2/3 of patients with diastolic heart failure at some point will develop AFib. So treating the underlying cause, so controlling your rhythm, or if the rhythm can't be controlled, your rate, it's also important to treat this type of heart failure. So, and then this is just another treatment option, a cardiac defibrillator. This is for the more severe classes of heart failure, and it's typically reserved for patients with a very reduced ejection fraction. They're mainly placed in the elderly. There hasn't been shown a clear survival benefit within the first 12 to 18 months, but the heart failure, it's difficult to say in the age of the patient population that gets it how much they help with life expectancy. But this is reserved more for the serious forms of heart failure. And if there are risks and benefits to it, just something to go over your doctor with having one of these devices implanted in your heart. So, yeah, this just kind of goes a little bit more over that cardiac defibrillator implanter. It's just mainly there to prevent sudden cardiac death as a result of long-standing or severe heart failure. Like we talked about, that heart failure causes your heart to remodel, and it can lead to arrhythmias. It can lead to things that can cause sudden cardiac death. This device is there to shock your heart in case that does happen. So I think that clears it up. I did want to touch upon one other thing in a previous slide for one of the medicines that we talked about, the lisinopril or the ACE. We talked about it helping with a mortality benefit. There is a good percentage of people who can't take it, though, because of poor kidney function. So it's really not, if your kidney functions are too poor, it's actually, it'll cause more harm than good to use that medicine. So some patients may be on hydralazine and a nitrate, which is a suitable alternative to lisinopril, an ACE inhibitor, or an ARB. And those medicines, they work by dilating your arteries, and then the nitrate dilating your veins to help with your heart getting oxygen. So that's some of you may be on that too, and that's an alternative to an ACE or an ARB if your kidney function or some electrolyte imbalance won't allow you to take one of those medicines. So I did want to touch upon that alternative. And yeah, thank you. Dr. Wright?
Yeah, anything that we should cover that we didn't? I know we kind of took up that whole hour, didn't we?
I think you covered it very well. I think they did a great job. Thank you, Dr. Vasanwala and Dr. Hoyt. I think they did a great job because this is a complex subject that I think they put in lay terms pretty well, although it's hard to get away from the complexities of it too. I might just tell you how we deal with it, how it comes up, and what the common presentations are in our clinic practice. And by the way, if you have a question, you've got time to call in on the phone, 479-200-9259. So please do. We love to have questions. So the common things would be someone who comes in with new onset of difficulty breathing, especially shortness of breath with exertion, but maybe it might be difficulty with breathing that keeps you from lying flat. That would be kind of typical of heart failure. Or difficulty breathing that wakes you up in the middle of the night out of a sleep, short of breath. There are a lot of things that can cause shortness of breath, but in the mix of what we would call the differential diagnosis of possible explanations would be heart failure. So anyone who comes in with new onset of breathing difficulty, swelling, especially swelling that's new or worse than a person's had before, really important for us as doctors to ask ourselves, can we be confident that this is not heart failure? And do we need to do tests or further evaluation to find out if it might be heart failure? Certainly in someone who already has known heart disease of any kind, among the things that your primary physician will be doing is, as they see you along for other things or for routine follow-ups, we'll be checking if there are any implications or symptoms or signs that maybe insidiously heart failure is developing. So, for instance, I mentioned swelling. Heart failure is not the most common cause of swelling of the legs. Most common cause is overstretched veins, or what we call chronic venous insufficiency. The veins don't work anymore to pull blood and fluid out of the legs, and so gravity causes fluid to pool in the lower extremities. That's very common, but we don't want to be misled and assume it's due to venous insufficiency and missed onset of heart failure. So we'll always be asking ourselves that and trying to figure this out. Same thing with the breathing. Are those questions?
Yeah.
Good. Good. Great. You got a mic turned on?
You can present the question.
Okay, we have a question. Thank you.
So we had a couple questions come in. One question I think is a good one to know. What's an acceptable blood pressure in a patient who is 80 to 85 years old who may have heart failure? So an acceptable blood pressure, it can range. It depends. Typically, even at this age range, we don't want to get above 140 on the top or 90 on the bottom too much. That may occur from time to time. We typically want a range that is around 110 to in the 130s above. It could be in the 60s to 80s, even 50s to 80s. And as we get older, that top and bottom number may get farther and farther apart. So that's a normal process of aging. It has to do with the stiffening of some of your blood vessels. So that can be a normal thing. But individually, we want those numbers in that range. That's typically a good range of blood pressures for a patient to have.
So yeah, like think less than 140 over 90, just because you're allowed to have higher blood pressure with increasing age, just because your arteries get harder, and it manifests as higher blood pressure sometimes. And another good thing to say is, if you are above 140 over 90 and you decrease your blood pressure with the medication and you start to become too dizzy because of it, well then for you, you might be an acceptable alternative to be slightly above that.
Right, and the fact that the questioner asked about being in his or her 80s, that is about when our targets change a little bit. We don't require quite, as they alluded to, quite as strict lowering of the blood pressure, but especially I think the point needs to be made that in addition to worrying about blood pressure being too high, we're concerned about it being too low as well. That can lead to problems, certainly dizziness and cognitive dysfunction, falls, but other things in terms of vascular deterioration. So you do want that checked out. And by the way, I'd like to say something here to reassure people not to overreact to intermittent elevations, as Tony Hoyt was just saying. It's a sustained elevation, so we're interested in where's your average typical blood pressure. Not that we're not concerned that it can occasionally go to 170 over 80, but that's not going to harm you if it just flashes there one day. But a sustained elevation like that, once we've convinced ourselves that it is a sustained elevation, needs to be brought down.
Okay, and we have two more questions. We'll try to hammer them both out. So someone was asking about swimming every day.
And yeah, we had a question about, is it, this patient swims every day and was just wondering, is this beneficial? Can this be harmful? Will this help? And if you can tolerate swimming every day, it's easy on your joints, you're not causing trouble to other parts of your body, then yeah, it can only be beneficial. It'll help with your endurance, it'll help with your weight, it'll help with some of the other things we talked about. So as long as your body can tolerate it and you're not overexerting yourself, that would be beneficial.
Yeah, let me just add that I presume this question means that if I'm prone to heart failure or if I have heart problems, is it okay to swim? And yes, it's still okay to swim, but we're even more concerned, as Dr. Vasanwala was saying, even more concerned that you're not overdoing it. Therefore, you want to either slow down or cut back or stop if you're getting very short of breath doing it. You want to stay active if you're prone to heart failure. Once it's really well controlled and your doctor gives you the thumbs up, you want to stay active. Walking at a controlled pace that doesn't lead to significant shortness of breath is an example. Swimming would be the same, but there's no advantage to trying to build endurance by going faster and longer if you're prone to heart failure. You want to stay active, but you don't want to overdo it.
We did get another question here too. Can diastolic heart failure be reversed with blood pressure control eventually? Can you reverse the effects of heart failure? And as much as I'm aware, I don't believe so. The progression can be slowed down by better blood pressure control and controlling some of these other factors, these other associated factors, diabetes, blood pressure, cholesterol, related to coronary artery disease. But it fully cannot be reversed, but the progression can be slowed down.
I would, kind of a caveat on that, I think it can be reversed a little bit. the wall thickness can be reduced that high blood pressure leads to. This left ventricular hypertrophy or wall thickening can be reduced. It can't be cured, and it can't be reversed completely. But
The boss has spoken. We agree.
okay. They get graded on how polite they are to the attending physicians also.
Those
are great questions.
I would say there's certain forms, like let's say you have a really hardened aortic valve and the blood's not escaping very easily. If you think about that one, if you reach the point of needing surgery and they can replace that valve or do some sort of a fixing of that valve, that essentially would make that strain a lot less hard on the heart. Now, you may have already thickened that heart muscle to a point where it can cause some sort of diastolic heart failure, but you have overall decreased your diastolic heart failure a lot. So there's a lot of reversal in that case. Anyway.
And we were discussing there's a lot of different conditions that can lead to heart failure. So a broad term is cardiomyopathy, a disease of your heart muscle, and there are different forms of it and different things that cause each form. Reversing those things, helping to working with your doctor to reverse those causes, those will also help tremendously with the heart failure that it eventually can lead to.
And that gives me an opportunity to make a point also that all the medicine that can be used, and every case is different, so it would be a different selection of those medicines, but all the medicines have an opportunity to reduce the heart failure so that it's no longer symptomatic and go from what we would call decompensated heart failure to compensated heart failure. So your heart's actually, with the benefit of that treatment, actually compensating for the stresses, the adverse stresses that would lead to heart failure. And that's where you want to stay. You want to stay in a compensated heart failure state that will give you a quality of life, allow you to stay active to a degree, and it is pretty impressive sometimes, people who have heart failure this year and can be treated effectively and for years stay out of active decompensated heart failure under proper treatment. So these medicines can make a big difference. And that's another reason I think that the term heart failure isn't an adequate term. It's a misleading term because failure sounds like it's failed forever, and you can't actually improve the cardiovascular dynamics in a way that has you performing well and functioning well. So good.
The semantics of the word reversal, but yeah, I think we have a good understanding now. So yeah.
Yeah. So was that the last question? Well, I thank you for those questions. I think it's much more meaningful when we get questions we can answer and know that we're actually hearing from people who that maybe our answers can be of use to you. Thank you for attending. Wait, I think the doctors did a great job, and I think I hear applause. I think I see a standing ovation out there, and for the great performance you guys did. And I think it was good, and hope everybody's doing well.
We need a sound cue, like something that claps, but maybe next time.
Yeah. I want to say, as I've said before in this,
there we go.
As I've said before in these this format, I want to compliment all the Butterfield Trail villagers that how well you've handled the pandemic. And I know many of you, I can hear you already saying, "Oh no, I haven't enjoyed this at all, and I'm depressed." And I think people have coped really well with it, and we're all worried about each other going through this. This is unnatural. But I tell people who ask, how the folks at Butterfield Trail handling it, I say, they're remarkable. This is a generation that's seen a thing or two. They know that no bad things last forever. It's just that we don't see exactly an end certain in sight. We know it's coming, but we don't know when. And I wish I could tell you when. We would all feel better, and I think we would all have more certain and immediate hope. But I want to compliment you. I think it's absolutely remarkable how well everyone has coped with this and handled this. And I just want to say, if you're feeling down or you feel like you're losing energy and losing interest and this whole thing has you down, be sure to talk to someone. And if it needs to be a trained ear or a counselor or someone, we could refer you. I think that's something we all need from time to time is, you know, a trained ear to help us sort through things when the going gets rough. But again, I want to compliment all of you. I think it's a remarkable community here that handles even really rough stuff like this really well. So hang in there. The time is coming when all will be celebration and party again. So thanks for your attention. Thanks for joining us, and we'll see you again next month. Thanks.